بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Good evening, everybody. It's my pleasure to welcome all of you to one of the scientific activity organized by Saudi Society of Nephrology and Transplantation. At the beginning, I'd like to introduce myself. I'm Mohammed Al-Sineid. I'm the consultant nephrologist. I'm currently a chairman of the Department of Medicine at King Faisal Specialist Hospital and Research Center in Riyadh. And also, I'm the vice president of Saudi Society of Nephrology and Transplantation. At the beginning, I'd like to welcome all of you to this scientific activity, which is organized by Saudi Society of Nephrology and Transplantation. This activity is sponsored by GSK company. And so I would like to take this opportunity to thank our colleague in GSK for sponsoring this scientific activity. I would like to thank our technical support group from the event group for their excellent work and the support that society we are getting to support this kind of webinar. This webinar is accredited by Saudi Commission for Health Specialty for 1 CME hours. And on behalf of the Saudi Society of Nephrology and Transplantation, I would like to thank our speaker today, Prof. Brad Rovin, and our moderator, also Dr. Samir Al-Qasimi, for accepting the society invitation. And also I would like to thank all participants for joining us tonight in this webinar. And I wish you all to really enjoy this scientific activity. Before we just start, I just have a couple of announcements I want to share with you that regarding the CME hours. 1 hour, it will be entered to the participant account who wrote the registration number in the registration form after 2 to 3 weeks from the webinar. And also just to draw your attention, there is no attendance certificate for this activity to be sent to any participant. So don't expect any certificate will be sent, but the CME hours will be entered automatic to your account. And just last point that really I want to share with you regarding the question related to this presentation, that please, if anybody has any question, please don't hesitate to place it in the Q&A site, which is shown in the screen, and it will be really shared with the speaker at the end of the talk by the moderator, and of course you will hear the answer for all your questions related to the presentation. So without further delay, I will just give the mic to our moderator tonight, Dr. Samir Al-Qasimi, to start the webinar. Dr. Samir, mic is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Thank you for joining us today in this webinar. Let me introduce myself to you guys. My name is Dr. Samir Al-Qasimi, Assistant Professor, Consultant Nephrology at Yazan University. It's my pleasure to be the moderator for interesting talk and presented with a big name from Prof. Rovin. Our topic today is going to be under title, We Finally Have Approved Therapy for Lupus. So now what? Just a little bit about our speaker today. Actually, if we can talk about him, we're going to take like a lot of time, but I try to highlight some of the areas in his field. Our Prof. Brad Rovin, he's a director of division nephrology, vice chair for research, Department of Internal Medicine at the Ohio State University, Wexner Medical Center. So our Prof. Rovin received his Bachelor of Science in Chemical Engineering from Northwest University, Illinois, He's Doctor of Medicine from University of Illinois Medical School in Chicago, Illinois. He completed his residency in internal medicine at Barnes Hospital, St. Louis, Missouri, and fellowship in nephrology, Washington University School of Medicine in St. Louis. Dr. Rovin had several leadership roles in American Society of Nephrology, including running glomerular disease, pre-course and co-editing for NEFSAB glomerular disease, continuing education program for the society. He is also co-chair for glomerular disease guideline development for the kidney disease improving global outcome, KDIGO. Dr. Rovin studies the immunopathogenesis of glomerular disease and autoimmune disease, and is heavily involved in clinical trials development, design for investigator-initiated and industry-sponsored trials. He has been a principal investigator for several trials on novel therapeutic glomerular disease, and we are lucky to have him with us to listen from him tonight. Just again, to highlight the point, the question will be discussed by the end of the presentation. Please type it down in the question box. And without any further ado, we will turn the time for Prof. Rovin to start his presentation. Welcome, Dr. Rovin.
Thank you so much for inviting me. It's a pleasure to be here. Coming from the middle of Ohio, the middle of the country. So I want to be a little bit provocative in this talk, and a lot of these data will be sort of how I'm putting together the current situation. But you have to understand that this is sort of a moving field, and as we get more experience with all the new drugs, these opinions may change. Okay, so just to be transparent, I will tell you I do work with pharma, and I have worked closely with both of the companies whose products we'll be talking with today, but I think I'll give you a fair and balanced discussion. These are some learning objectives. So I want to just say where we are right now. You all know that the US FDA has approved voclosporin and belimumab for the treatment of active lupus nephritis. We also know that adding voclosporin or belimumab to background immunosuppressive therapy significantly increases the number of complete renal responses at 1 to 2 years. And let me just show you the top line data. And this upper panel is the BLISS-LN trial with belimumab. As you will recall, they had a fairly non-traditional endpoint, which was called the primary efficacy renal response. And then the secondary endpoint, the major one, was complete renal response. So I know all the trials have different endpoints, but complete renal response is generally a somewhat preserved GFR, and then a proteinuria that's less than 500 milligrams a day. The PERR is a little bit different because the criteria are a little bit more lenient. So the proteinuria had to be less than 700 milligrams per 24 hours, and the GFR had to be above 60, but it could be as much as 20% lower than baseline. Okay, the other really important factor for the BLISS-LN trial is that it was a 2-year study, okay? So one of the first studies for 2 years, and that, I'll show you some of the data, that allows us to learn more things about how the drug works that are really quite important. So you can see here, this is the placebo group, and this is the belimumab group. And you can see that both for the PERR and the complete renal response, there was an increase, a statistically significant increase in the number of responders at week 104. And the difference between placebo and response was in favor of belimumab by about 10%. Okay. Below are the belimumab, are the voclosporin data. And so what I did with the voclosporin data is I took the phase 2 trial and combined it with the phase 3 trial because they were very similar, using the same dose as the phase 3 trial. And this is now a compilation of data from over 500 patients. And you can see that at 6 months, the patients in the voclosporin group had already a significantly increased number of complete renal responses. and then by 1 year, this difference between placebo and the voclosporin group increased to about 20% and was highly statistically significant. So both of these drugs seem to work. Now, the other thing is that this can be done safely. So when you think about what we're doing, we're taking pretty good immunosuppression and adding more immunosuppression onto that. And so you worry about the safety signal. These are sort of the top line safety data that I compiled from the whole list of adverse events. And so you can see that if you just look at all serious adverse events, belimumab or placebo, you can see that they're similar in both groups, as well as voclosporin and placebo, separately for each trial, of course. Serious infections were a few, and you can see that they're similar in both groups. The patients discontinuing the trial because of adverse events were, again, similar in both groups, and there were very few deaths, fortunately. Now, we know that achieving a complete response should really lead to better preservation of kidney function over the long term. I like to show this graph. This is from the Rush group, and this is kidney survival in lupus patients. And of course here, these are the patients that have a complete response, and you can see that they do well over a very long time. As expected, patients who don't respond do poorly in terms of kidney survival. But this line are the partial responders. These are sort of, we see a lot of partial responses. We sort of congratulate ourselves that we have the patient under control, but do we really? I mean, is it enough to control the proteinuria? And I would say no. What we really want, of course, is not to have the patient go on to renal replacement therapy. And you can see that over the long term, patients who only achieve a partial response don't do very well. And I want to come back to this right at the end. So what should we do? At least in the United States, where both of these drugs are approved, we could just treat everyone with background immunosuppression and add belimumab or voclosporin. And if we do that, this is a very short talk, but there's always a but. And I'll just pose the question, what drug should we add? We really have no biomarkers to identify who's going to benefit most from belimumab, who's going to benefit most from voclosporin. These medications are very costly, and this is probably going to be a barrier for many patients, for sure in the United States, and also probably in many other parts of the world where this would significantly add to healthcare costs. And I want to take a little side trip into healthcare economics here, because I think it's important. This cost analysis was recently published of belimumab and voclosporin in CJASN. And they assessed the incremental cost effectiveness, that's called ICER, in terms of quality adjusted life years, okay? This used very complex modeling, and they made several assumptions and extrapolations from existing data set. And I'm going to show you the assumptions on the next slide, and we can judge whether or not they were fair assumptions, because I have some questions about that. Nonetheless, I'm not a healthcare economist. I cannot describe how the models really work, but these are the results, just to show you some numbers. This is the cost effectiveness per quality life year for belimumab is computed at $95,000 US per year, and for voclosporin, $152,000 per year. Now, because belimumab can come in a subcutaneous form, patients can give it home, this is a little bit cheaper. If you look at the effectiveness per life year gained, this is estimated to be over $100,000 for each of these medications. And then for insurance, at a willingness to pay level for insurance of $150,000 per quality life year for a rare disease, belimumab is estimated to be about 70% effective and about 50% effective for voclosporin. But here's some issues that I think we should discuss. First of all, these are the assumptions that were made in doing these calculations. the data from the trials were assumed to be sustained for 3 years. So when I put this all together at the end, but you already know this, the number of remissions at the end of each trial, complete renal responses, was less than 50% in each active treated group. So I would hope that we would see remissions continue to accumulate over time, or we would do something else with our patient. That's number one. Number two, treatment with each drug was assumed to be for 3 years unless an adverse event occurred, and then treatment was assumed to stop at 1.5 years. Well, I understand you have to do that for modeling, but I don't think the idea is that we're going to use voclosporin for 3 years, maybe for class 5, but probably not. Belimumab we might use longer, and certainly in non-renal lupus it's used longer. And if we had adverse events, these medications would be stopped much more quickly than 1.5 years. Complete renal response and partial renal response were assumed to result in the same kidney failure-free survival. And then when they modeled that complete renal response was better, they did it with a very minimal hazard ratio improvement of 0.94. So I just showed you data which suggests that a complete renal response and a partial renal response don't have the same long-term prognosis. And finally, quality of life was not reported in either of these trials. And so this was based on extrapolations from the literature, patient interviews, and expert opinion, again, bringing into some question the applicability to this analysis. Nonetheless, that's what we have. So let me pick up this list. There's a couple other things you need to think about. The new medications don't really reduce the immunosuppression burden for the lupus patient. And while I just showed you that adding them to background therapy is safe in the short term, long-term safety data are lacking, especially for voclosporin. Now, a lot of folks, especially our rheumatology colleagues, have been using belimumab for 2 decades, and we know long-term use is pretty safe with belimumab. So I think we can understand that. This is really important, and I'm sure your patients are like my patients. Adding on to background therapy increases the pill burden or the polypharmacy for patients who already have adherence issues. To treat a patient with voclosporin, because the pills come in a 7.9 milligram size, you take 6 additional pills a day. And that's on top of mycophenolate, on top of glucocorticoid, on top of hydroxychloroquine. So you can see right away, you're really challenging these people to take these medications. And finally, and maybe most importantly, a significant proportion of patients will respond to background therapy alone, and we don't know how to identify those patients yet. So how do we resolve these issues? And I'm going to suggest a deeper dive into these trials is really informative. So let's start off with the voclosporin trials. You all know glucocorticoids are used for all lupus nephritis patients, uniformly disliked by patients, and have a litany of long and short-term adverse events. So this is the steroid regimen in the voclosporin trial, and this was rather unique. They had a forced steroid taper after receiving 500 to 1,000 milligrams of intravenous methylprednisolone, and we started glucocorticoids at 20 to 25 milligrams per day of prednisone. That comes out roughly to about 3.3 milligram per kilo per day. And you can see how rapidly this was tapered. And then after 12 weeks, patients were, by and large, on 2.5 milligrams of prednisone a day for the rest of the year. Remarkably, 80% of the patients achieved this during the trial. So this was very effective. So I suggest that the combination of voclosporin and mycophenolate can be given with very low dose, rapidly tapered glucocorticoids. I also suggest that this is likely to improve patient adherence and reduce short and long-term adverse events. The first drug they're exposed to is generally a glucocorticoid, and often they have side effects right away from that. Okay, subgroup analysis is really important as well. And so one of the things that we need to consider in these trials is that lupus and lupus nephritis affects a very diverse patient population, and patients, at least in our country, who are African American or Asian, or Hispanic tend to have very severe disease compared to white patients. And you can see here that throughout all of the ethnicity or all of the races here, Asian, Black, and other, voclosporin was effective. Additionally, between ethnicities, so Hispanic or non-Hispanic ethnicity, voclosporin was effective. This is really a little bit of a surprise, but maybe not so much. We all use calcineurin inhibitors, probably in some of our other proteinuric diseases like idiopathic or PLA2R membranous nephropathy. Voclosporin had a positive point estimate suggesting effectiveness. However, it crossed the line of unity in this forest plot, and it was not statistically significant. Now, two things really to think about. One is, you and I all know that the tempo of response in patients with pure class 5 lupus nephritis is not necessarily as rapid as the response in patients with proliferative lupus nephritis. Secondly, not very many pure class 5 patients were enrolled in the voclosporin trial. So I suspect if there were more and we had more time to follow the patient, that we would have seen this to be statistically significant. And finally, and this is sort of interesting, if you look at the patients, if you just look here, patients who are using mycophenylated screening or not using mycophenylated screening, patients who are using mycophenolate actually did remarkably well. So this gives you the idea that with background immunosuppression, adding on the voclosporin did well. Okay, so how about the rapidity of proteinuria resolution? So you can see here that this is the probability of achieving a urine protein to creatinine ratio less than 0.5. And you can see that within days of adding voclosporin, you started to see the curve separate from the placebo curve. Voclosporin is in blue. And this continues throughout the study and widens over time. I think you'll all agree that if we have a rapid anti-inflammatory response, that is good for the kidneys and is kidney protective. The very rapid response that we're seeing with voclosporin is almost certainly not due to its effect on T cells, but is due to its effect, the effect of general in calcineurin inhibitors on podocytes. But I suggest to you that the podocyte effect is also kidney protective. So let's talk about, this is one of my favorite phrases, time is nephrons, the benefit of a rapid response in lupus nephritis. And this is illustrated, I'm using one example, there's many examples in the literature. This is a single center study out of Europe. These are all brand new cases of lupus nephritis, biopsy proven. They were followed for a very long time. And renal remission was defined as a urine protein to creatinine ratio of 0.5 on 2 occasions. And creatinine couldn't be more than 20% of baseline, 20% higher than baseline. In this cohort, the median time to renal remission was 7 months. And so they decided to call early remission 7 months or less and late remission after 7 months. They divided the cohort up into early remitters and late remitters, and you can see it was about 50-50, and you see the duration of follow-up. The eGFR is better preserved, and this is statistically significant in the patients who achieve an early renal response. About half the number of patients who had an early remission went to develop CKD, defined as a GFR less than 60, compared to the late remitters. Now, this did not quite reach statistical significance, but it's sort of trending. Now, what about with voclosporin or a calcineurin inhibitor? So you all know, you're all nephrologists, you all know that the podocyte and that calcineurin itself mediates the dephosphorylation of synaptopodin. That makes it susceptible to degradation by cathepsin. Synaptopodin is absolutely critical for stabilizing the actin cytoskeleton, and CNIs protect the podocyte by doing this. And this is a really cool experiment, I think, and I want to show it to you. So this is looking at a different calcineurin inhibitor, tacrolimus, but in the lupus mouse model, the MRL-LPR mouse. And so what the investigators did was the mice were born, and then they were kept 8 weeks. And then from week 8 onward, that's when the MRL LPR mice start to develop lupus nephritis. Then you had normal mice, MRL mice, and MRL mice that were treated with tacrolimus. And what I'm showing you here is RNA blot. You can see here, this is the RNA as a graph. And you can see here that synaptopodin RNA is normal in the normal mice. It decreases remarkably in the mice that are having lupus nephritis, the MRL mice, and it's preserved in the mice that have been given tacrolimus. If you look at the number of podocytes, you can see that in the MRL mouse, this declines, and the number of podocytes remains stable in the mice treated with tacrolimus. I love this picture. This is a really cool result. This is what the MRL LPR mouse foot process fusion looks like in the untreated mouse. And this is how well the podocyte foot processes are preserved in the mice on tacrolimus. And this also preserves slit pore density. So why do we care about preserving podocytes? And I think you all probably know this. This will be review. These are human disease. This is the glomerular capillaries are in red, and the podocytes are stained in green in WT1. This is what we're staining for. And you can see here, this is normal control, and there's lots of podocytes in a glomerulus. As you start to get microalbuminuria, I know that's not the terminology anymore, but I still like it. Microalbuminuria, you start to lose podocytes. You really start to lose podocyte density when you start having larger ranges of proteinuria. As you lose podocytes, this is 10% loss, 20% loss, 30%, 55% loss, you start to develop glomerulosclerosis. And of course, GFR and podocyte number is directly related. So you have your complement of podocytes doing well. As you lose podocytes, GFR declines. In fact, if you look at some of the work from Roger Wiggins from the University of Michigan, he suggests that if we lose a certain number of podocytes above a threshold, maybe 40%, and you know, these are thought to be end-stage cells, right? We don't know that they can regenerate, maybe from the parietal epithelium in Bowman's capsule, but that's still a little bit controversial. If you lose a certain number of podocytes, your nephron is going to be lost, even if you stop the disease that was causing the problem. Okay, that's really important. So we want to preserve podocytes. Okay, nephrotoxicity with a calcineurin inhibitor. Of course, we know about this in our transplant patients, and this is a very sticky question. We don't know whether or not voclosporin is less nephrotoxic than the other calcineurin inhibitors. There are some hints. All these are hints. Nothing I'm saying right here should make you walk away from this lecture and say, Rovin says it's not nephrotoxic. This is undergoing investigation, but I think this is sort of interesting. I didn't know this, but rabbits are particularly susceptible to calcineurin nephrotoxicity. These rabbits were either untreated, the control group, they were given cyclosporin, or they were given low dose and high dose voclosporin. And as you can see here, in the cyclosporin treated animals, the serum creatinine increased over the first 30 days. This is a 1-month study. And you can see here that in the voclosporin groups, you don't see an increase in serum creatinine, suggesting less nephrotoxicity. Now, you see, in fact, a decrease in serum creatinine here. I don't believe that for a minute. This is just experimental variation. What about humans? There are no studies directly comparing, so I've cobbled together a bunch of data. This first set of data are from transplant patients. And what we're looking at here are transplant patients treated with cyclosporin and transplant patients treated with voclo. However, this was not in the same study, so this is not a direct comparison. It seems that way because I made a table out of it, but that's not the way it was. You can see here renal dysfunction occurred in 1/4 to 1/3 of the cyclosporin treated patients. None of these transplant patients had renal dysfunction in the voclosporin group. Okay, this is using a calcineurin inhibitor in people with normal kidneys who have psoriasis. And here are cyclosporin and voclosporin treated patients. And you can see here that in this particular study, about 20% of the patients developed an increased serum creatinine if they were being treated with cyclosporin. If you look here in this particular study, they looked at GFR. So at a very low dose of voclosporin, nobody showed a reduced GFR, but at doses that are similar to the dosing used in the Aurora trial, that's these doses, a small number of patients did develop a reduced GFR, okay? One final bit of information. After the phase 3 trial, patients were kept on their drug if they wanted to stay 2 more years in the trial. And so this blue line are patients that have been treated continuously for 3 years. This is data up to 30 months. This was presented at the ACR last year. I think at the EDTA that was last week, they presented the 36-month data. But the point is that over 3 years, you can see that voclosporin patients, they had an initial decline in GFR, which is expected. It's hemodynamically based, and then it stayed stable. Does this mean no nephrotoxicity over 3 years? No, of course not, because you can have pretty good fibrosis in the kidney before you start to see a big decline in GFR. It'd be nice to have some biopsies here to look at this. But the point is, we're not seeing overt suggestion of increased nephrotoxicity. A question that remains to be resolved. Okay, I'm going to take a deep dive into the BLISS trial and then integrate everything for you. One of the things we did, which I think conveys much more information for you to understand how to use these drugs, is a subgroup response in the belimumab trial. So if you remember, the investigator at each site in the BLISS-LN trial was allowed to choose the background therapy, either urolupus cyclophosphamide or mycophenolate. And what you see here is that belimumab did well, but that was driven almost entirely by patients who were receiving mycophenolate background therapy and not on top of cyclophosphamide therapy. Okay, one hint. The second hint, histology. The belimumab responses were driven mostly by patients with proliferative lupus nephritis. If you added class 5 to the proliferative component, still had a good point estimate, not quite significant. Nothing in class 5 patients, okay? And the same thing for complete renal response. Now, similar caveats apply. This was a longer trial, so 2 years, compared to the Aurora trial, which was 1 year. This also only enrolled a small percentage of pure class 5 patients, but we don't really have a signal here for class 5. This is a really important observation. We divided baseline proteinuria, what the patient came into the study with, into low, which was 3 grams, less than 3 grams of proteinuria a day, or high, 3 grams or more per day. And what you see here is that belimumab works well in the low proteinuria group, does not work well in the patients with a large amount of proteinuria. Okay. On the flip side, some really interesting data. Because this was a 2-year trial, we were able to look at lupus nephritis flares in the belimumab and placebo-treated patients. And what you see here is there were fewer, significantly fewer lupus nephritis flares in the patients receiving belimumab, and that transcended all of the subgroups I just showed you. This was true in cyclophosphamide-treated patients, mycophenolate-treated patients, proliferative lupus nephritis, and proliferative lupus nephritis or class 5 lupus nephritis. So that's really interesting and important. We are also able to understand what the effects might be on kidney function over that 2-year period of time. Our FDA is starting to look at slope of GFR as a way to understand if you're preserving GFR in clinical trials. And a negative slope, of course, means a decline in GFR. And what you see here is a decline in GFR in the placebo group that is numerically far higher than the decline in the belimumab group. Now, this did not quite reach statistical significance, This is a post hoc analysis. The study was not powered to look at this, but you sort of get the idea that maybe in the future we can look at these sorts of things in clinical trials, which would be good. We looked at a 30%, a sustained 30% decline or 40% decline in eGFR. And you can see here that far fewer patients in the belimumab group hit this these are bad metrics. Of course, this is a sort of harbinger of renal failure down the road. And these were both statistically significant. So it seems like belimumab is trying to preserve kidney function in our lupus nephritis patients. Okay, so I'm gonna propose this. This is my current algorithm of how I consider using these new drugs. And again, I'm going to reiterate, this is fluid. As we as a community get more idea of how these drugs work and in whom they work best, this is liable to change. So let's spend a little bit of time with this. I'm suggesting class 3 or 4 lupus nephritis, plus or minus class 5. You see I've left out pure class 5, but I think probably calcineurin inhibitor will work in pure class 5. Methylprednisolone to prednisone, modest dosing. And then treat the patients like you would normally treat them right now, urolupus or mycophenolate. However, monitor the patients closely for 2 to 3 months. And if they're stable or improved, and that means their GFR is getting better and their proteinuria reduces by 25%, they're probably going to do pretty well on the regimen you have them on. And I would continue that therapy. Okay, so wait a minute. Where did I get this from? And is this even remotely okay for the new drugs? So let me try and convince you of that. Okay, if you remember a while ago, we did the mycophenolate versus cyclophosphamide trial called ALMS. And this was a post hoc analysis of the ALMS trial. They looked at parameters at 2 months of treatment that predicted a 50% decline in proteinuria by month 6. And the one that really stood out was a decline in proteinuria by 8 weeks of 25% with this really good odds ratio. Couple that with these data from Fred Husio's work, and this shows that patients who achieved a 50% decline in proteinuria by month 6 of treatment maintained good renal function over 73 months of follow-up. Okay, so this is a lot of stuff all at once, and I'm throwing it at you very quickly. So I'm going to summarize it. A fall in proteinuria of at least 50% after 6 months of therapy is good and predicts good long-term kidney function maintenance. A fall in proteinuria of 25% after 2 months predicts this fall in 50% at 6 months. Now, everybody's an individual, of course. I expect there's a little bit of wobble room here. So my suggestion is that it's reasonable to expect an improvement in proteinuria of at least 25% after 2 to 3 months of induction therapy in patients who are going to do well on the treatment you have them on, okay? This timeline balances a sufficient duration of treatment to see an effect. Can't get rid of it too quickly, but you don't want to keep an ineffective therapy on board for a long time because that's, you're causing chronic, or you're allowing chronic kidney damage. You can say, okay, wait a minute, that's not how these trials were done. They added the medications up front. Is it okay to wait to add belimumab or voclosporin to see how the patients are doing? And I'm going to suggest yes. And why? So remember, I showed you this sub-analysis of the Aurora 1 trial. Here, patients on mycophenylated screening, in other words, having some immunosuppression on board, after voclosporin was added, did really, really well. These patients did well as well, but it wasn't quite statistically significant. these data were presented, they're not published yet, but they were presented last year at the ASN. We're working on the publication now. These are patients treated in the BLISS-LN trial, segregated by relapsers, so people who have had exposure to immunosuppression, or newly diagnosed lupus nephritis. And what you see here is the relapsers did really well. So I'm going to throw out my interpretation, and you don't have to interpret this way, but this is my interpretation of the study, is that the best results in terms of renal response are seen in patients who've already been exposed to immunosuppressive therapy. Okay, so let me keep going here. So that's how I came up with this part of the algorithm. So let's say the person goes 2 months or 3 months and their proteinuria doesn't really improve by 25%. So the answer is no. Now, I think you should consider adding one of the new medications. And you can add either belimumab, or here I put a calcineurin inhibitor because voclosporin hasn't been approved all over the world, but we're talking about voclosporin today. So how would you decide which to use? This, again, is a little bit problematic, but a couple of pieces of advice. One is our FDA suggests that voclosporin's label that you don't use it in a GFR below 45. Now, as nephrologists, we tend to play with those numbers a little bit because we're comfortable with calcineurin inhibitors. We watch the patients closely. We see what's happening to their serum creatinine, et cetera. So this is a suggestion. If they have severely chronically impaired kidney function, maybe not start off with a calcineurin inhibitor. However, you know that a lot of patients will enter into your care with acute kidney injury. And as you start to treat them, they will improve their GFR. They don't have chronic kidney damage. They have AKI because of their lupus, and then you might want to fold in a calcineurin inhibitor. I would suggest that in patients with a large degree of proteinuria, belimumab might not be the best drug. I have also indicated that I would use a background of mycophenolate on both of these medications. Cyclophosphamide and belimumab did not seem to show benefit. And of course, the calcineurin inhibitor was not tested against with a background of cyclophosphamide. No reason it shouldn't work, but it wasn't tested. Okay, do the same thing. 2 to 3 month follow-up, following closely. Is the patient getting better? If they meet criteria, then continue the therapy. They're probably going to do well. If the patient is not getting better, then you need to verify adherence. If the patients are really taking their medications, consider treatment for resistant disease. I'd like to segue a little bit into resistant disease because we always get those questions. These are some of my thoughts on refractory or resistant disease. It's really critical to define what we mean by refractory lupus nephritis. And here's a definition that I like, and you might like too. This is no response or worsening to 2 different initial therapies after 4 to 6 months in patients who are taking their prescribed medications correctly and in doses that are generally believed to be therapeutic. So I'm incorporating a lot of stuff in this definition. It incorporates adherence. I would tell you, and you probably already know this, that probably 80 to 90% of refractory lupus is that the patients aren't taking their medication. This also incorporates the idea of drug dosing. I got a referral not too long ago for a patient with refractory lupus nephritis. I'm talking to the patient. And I said, so what are you taking for your class 3? I'm taking 500 milligrams twice a day of mycophenolate, except when COVID came, I decided to reduce to 1 pill a day. Taking 500 milligrams once a day of mycophenolate, clearly an insufficient dose. And so I don't think she was refractory. I think she was undertreated. You also have to give enough time for the medication to work. And you don't want to give too much time where something's ineffective, as I said before, because you can get buildup of chronic kidney disease. Here's some data on adherence. This is from our rheumatology colleagues. Adherence to immunosuppression is poor in patients with autoimmune disease. This is from a US Medicaid database. They looked at adherence of over 4,000 patients with lupus, not necessarily just lupus nephritis. They were started on azathioprine or mycophenolate and assessed over the first year of treatment. And adherence was assessed as getting refills greater than 80% of the time, okay? 4 different trajectories were modeled for each drug. You can see here that a very small number of patients took their azathioprine or their mycophenolate through the duration of the first year. Almost everybody started dropping them. About half the patients stopped taking their medication pretty quickly, maybe never even started their medication. We see this over and over again. We have to fix this. How do you assess adherence? There's multiple options. None are ideal. You can have an open discussion with the patient. You can do pill counts and refill verification. I think this is really cool. I was reading about this a while ago. These are called smart pills. They have a little electronics inside. So when you swallow them, they ping your cell phone and they say the patient took the pill. Of course, the problem was the little electronics started to build up in the patient's guts. So that probably is not a really good idea for long-term use. I do use biologic changes. So you know the patient is taking steroids if they develop cushingoid-like features, et cetera. Drug levels are really probably what we should do. Hydroxychloroquine levels are particularly useful because it has a very long half-life. If you have a low level or a 0 level, it cannot be, doctor, I didn't take my drugs today on the way to clinic. Okay, it can't be that. That means they haven't been taking their medication. Similarly, levels don't get into therapeutic range if the pills are taken only around a scheduled visit. So this is a particularly good one to assess. How do we improve adherence? If you have a way, I would love to hear it. I don't know. Multiple options, but I think for most of our patients, there's a big movement, at least in the United States, called health literacy, educating patients on how they participate in their care, understanding the disease and how important it is. And I think that's really very, very key. But you can see what also will affect adherence. Cost reduction. If the drugs are too expensive, you're not going to get it. Pill burden reduction. If you're taking 20, 30 pills a day, that's a problem. And then I also suggest, like I said before, if we reduce side effects and reduce or eliminate glucocorticoids, as an example, you know, we get the patient buy-in right away. If the first thing they take makes them feel terrible, it's hard to be adherent for the rest of the therapy. Okay. What's my first line treatment for resistant disease? Well, let me preface this by saying there's no good studies. I'm showing you Rituximab. I'm showing you Rituximab because there are enough studies on Rituximab that still aren't very good, but enough studies have accumulated that there's been 2 meta-analyses on Rituximab for refractory lupus nephritis. Now, first problem is the definition of refractory lupus nephritis in all the studies was different and maybe not as rigorous as what I just showed you. Second, you can see in this particular meta-analysis, the background therapies were all over the place. The Rituximab dosing was all over the place. Nonetheless, this meta-analysis covered 26 studies, evaluated 300 patients, and what you see here is in patients who were presumably refractory, 40% of those patients did better after Rituximab was added with a complete response. Another 30% had a partial response, and then another quarter didn't respond at all. This is a second meta-analysis. It covered 10 studies, included 233 refractory patients. And let's just bottom line it here. The event rate was about 50%, which means about 51% of refractory patients had a complete response after starting on Rituximab. So data are not great, but these are the best data we have. Here's the problem. Oh, okay, one more thing. The overall degree of immunosuppression really needs to be taken into account and the individual risk for infection in these patients, because most patients who are refractory have received lots of courses of immunosuppression and lots of different types of immunosuppression. So you really need to consider that, because once you're done with the Rituximab, if they respond, you probably need some maintenance. I get quantitative immunoglobulin levels to assess the overall level of immunosuppression and whether or not immunoglobulin supplementation might be needed. And that might be useful for you too. Okay, so you give rituximab, you assess the response. If they have a partial or complete response, you choose something to keep them under control. If you have no response to rituximab, the field is wide open. There's been a whole bunch of proposed medications and regimens to look at refractory disease. I'm particularly interested here. I've listed them in my order of importance. Anti-CD38, so plasma cell therapy followed by B-cell therapy, leflutamide, intravenous immunoglobulins, so IgG modulates the immune system. This may be particularly useful in patients subject to infection because it is not immunosuppressive, it's immunomodulatory. But the truth is, these are mostly based on very small series or a collection of case reports. Nothing's been done systematically. So this is really what we would call a gray zone. We don't really know what to do. Okay. I come back to this. I mentioned this a little bit at the beginning. If you look at all of the data together from the voclosporin trial and the Bliss-LN trial, and I've thrown in the Obanituzumab trial, even though I didn't discuss it. Obanituzumab is like rituximab. I'm sure you've heard of it. Had a very successful phase 2 trial. You can see that no drug, no placebo therapy, no drug, 6 months, 12 months, or 24 months exceeds 50% complete renal response. That means over half the patients in these trials either had no response or they had a partial response. And I showed you that a partial response it's better than no response, but it should not be the response that we are looking for. And so we're not done yet. And I just have a little table here showing a lot of medications that are under clinical trial right now, okay? And just very briefly, we're targeting the complement system. We're targeting interferon alpha or type 1 interferons. We're targeting inflammatory cytokines, the immunoproteasome, all sorts of really cool ideas to try and get better control of lupus nephritis. So this is an exciting time. These 2 studies were pioneering in that we finally showed we could get a drug approved through the US FDA, but we're not done. So I have one last slide. And this is just, again, provocative and hopefully will stimulate some discussion. Maybe it's time for something completely different. Maybe we need to start rethinking things. So this is a little proposal I have. We are going to work with some of the companies to see if we can do this sort of study. But here's an idea. You already have you get a diagnosis of lupus nephritis. So the first thing you want to do is proliferative lupus nephritis. Treat with intravenous glucocorticoid. Why? This rapidly controls inflammation right now. It's the best thing we have. I know that it's glucocorticoid, but intravenous glucocorticoid, 1 to 1.5 grams, will provide inflammation control for some long period of time, allowing the other drugs to catch up. Then you could start oral glucocorticoid in the dose needed for extrarenal disease, lowish. Simultaneously, begin treatment with voclosporin. Why? I want to get rapid control of proteinuria. As you know, excessive proteinuria through the tubular interstitium causes tubular damage and also can cause tubulointerstitial nephritis. I want to preserve podocyte integrity, and I'm going to continue this drug for maybe a year, maybe a little bit less, and then stop. Simultaneously, and I'm hitting the T cells, okay? So now I've hit inflammatory cells right away. I'm now targeting the T cell longer term, and now I want to start belimumab at the same time. Belimumab took about a few months to kick in, as do most B-cell therapies. Why am I adding belimumab? What I want to see is not necessarily for remission, but now I'm targeting the B cell to prevent lupus nephritis flares, which more and more flares predispose to chronic damage, and to preserve GFR. And so what I'm looking for, and this is going to be a longer term treatment with belimumab, 2 years, maybe more. GFR stability is what I'm looking for. I want resolution of proteinuria as much as possible, and I want the patient not to flare. That's what I would define as kidney success. And I think as we have more and more new drugs, we are going to probably play around with combinations and find combinations that work for individual patients. So I think I'm done. I am. And I'm happy now to really take some questions. I hope this has been provocative and there might be a lot of questions. So I'm set to go, whatever you want. Dr. Samir, you're on mute. I can't hear you.
Me. Now we're good. Okay. Thank you very much, Rovin, for this very interesting talk. And I think those areas is new for a lot of attendee today. So we have a couple of questions here. We're going to go over that, and hopefully we can have more questions during the discussion. So the first question from Dr. Fahd Shehri, and the question talking about, we have two groups of patients, and one group receiving mycophenolate more than 2 grams, and other group receiving less than 2 grams. So the question is, or the point is, why patients receiving more than 2 grams is not responding well with the voclosporin comparing to the patients receiving less than 2 grams of mycophenolate?
Yeah, you know, that's sort of an interesting question. And you know, is it possible? I honestly, I don't know the answer to that, but is it possible that, you know, well, one of the considerations early on when all of our lupus nephritis trials were failing and most of us were frustrated was we had so much background immunosuppression on board. Were we ever going to see the effect of a new drug? And so that might be one consideration here. And of course, then you might say, well, if that's the case, do you need the voclosporin or the add-on, or is it sufficient just to really up the dose of the mycophenolate? And again, I don't know the answer to that. I will tell you that in my own practice, I have really tended to use less mycophenolate. I used to use a lot, up to 3 grams a day. The toxicity really gets to be pretty considerable in those patients. And yes, I do what you do. If the patient starts having a lot of GI toxicity, I switch them from mycophenolate to myfortic, and in some cases that helps, et cetera. But I've also had bone marrow suppression and things of that nature. So the idea of using a multi-targeted approach is very appealing, and it should be very appealing to nephrologists, especially because we've been doing that in transplant for whatever, 4 decades. Now, I'm going to take a corollary to your question that you haven't asked because I think it's important. And I want to, you know, some criticism of the Aurora design was that we used 2 grams of mycophenolate, and in my clinic, I probably use 2.5 and occasionally 3. You do too, probably. Was the trial positioned to favor the result with the voclosporin? Okay, you see what I'm saying? So in other words, the placebo arm did not receive 3 grams of mycophenolate. It was limited to 2. So the group at San Francisco did a reanalysis. They did propensity matching of patients from the ALMS trial who received 3 grams of mycophenolate to the placebo arm of the Aurora trial who received 2 grams of mycophenolate. And they showed at least up to 6 months that the responses were similar, suggesting that we didn't put an advantage on the voclosporin arm. That's as much as I know right now, data-driven, but those are relevant questions. I think ultimately what we want to do is find a combination of drugs that make sense immunologically, knowing all the components of the immune system that are involved in lupus and lupus nephritis, but that are very, very well tolerated, so patients will take them.
Okay, sounds good. A couple of questions here also. You may mention a little bit about it, but it's okay to highlight it again. So a question here say, what would you say about using Rituximab as alternative to Belimumab?
Yeah, so this is really an interesting question. As you know, the trial of Rituximab testing this question failed, right? The LUNAR trial did not show benefit. However, there's a big but. When we did a reanalysis of that trial, and this was published maybe 2 years ago or 3 years ago, it was right before the pandemic. That's how I define my life now, pre and post-pandemic, unfortunately. Right. We did a reanalysis of the LUNAR trial, and we found that if you looked at the patients who had complete peripheral B-cell depletion using routine flow cytometry, not high-level flow cytometry, high sensitivity, those patients actually did improve dramatically. So when we think about the LUNAR trial failing, there were a lot of potential reasons it failed, but what I'm concerned about now is that we did not hit the target we were intending the way we thought we were doing. And that really came out when you started looking at B-cell depletion in patients receiving Obanituzumab versus patients receiving Rituximab. And I think this is very informative. Obanituzumab causes about 95% of the patients within 2 weeks to have no circulating B cells. If you look at the trajectory of B-cell decline in the LUNAR trial, it really took several weeks to get to that level. And that level of 95% was not sustained. It went away fairly quickly. Why? A lot of reasons, but Obanituzumab, one that I favor quite a bit, is Obanituzumab does not require complement for cell killing, whereas Rituximab is dependent on, there's several mechanisms of cytotoxicity, but one is complement-dependent cytotoxicity. In a lupus nephritis population where complement may be being consumed and is not available, I think that's a problem. So I'd rather you ask your question is, what do you think is going to happen with Obanituzumab? I think it's going to work. And again, I work with the company, so take that with a grain of salt, but I do think it's going to work. And we're involved in the trial. And I think then the question is, what do we do with that and Bliss? So I got an idea for that too. So you're letting me talk a little bit, right? It's okay to pontificate a little on these questions, yes?
Yes,
okay.
Yes.
Okay, so what's really appealing, if you look at what happens when you start to kill B cells with any drug, cyclophosphamide, Rituximab, Obanituzumab, the response is that the B cell growth factors like Bliss go way up. So it's a very appealing idea that you could come in with an anti-CD20, kill the B cells, okay, and then maintain the patient with a drug like Belimumab to keep Bliss under control. Because when B cells repopulate in a high Bliss or BAFF environment, Bliss and BAFF are the same thing, you really get proliferation of autoreactive B cells, okay? So that is not desirable. So now you say, well, you know, there was a trial like that, which there was. It was conducted by the Immune Tolerance Network. And it was done, it was sort of a bizarre setup, but the idea was treat with cyclophosphamide and Rituximab up front, and then add Belimumab on and see how the patients did. They looked at short-term response. I think the idea is you look at long-term response. Instead of remission, the more ideal study would have been to power it to look at flare prevention. because the idea is if you eliminate B cells and then you bring back a lot of autoreactive B cells as the B cell drug wears off in a bliss environment, you set yourself up, I believe, for flare. And if you have belimumab on board, maybe you prevent the flares. And that's also profitable in renal disease, because the more flares you have in most studies, the more propensity you have to go on to end-stage kidney disease over time.
Great, thank you. Another question talking about, what's your comment about those two medications in context of pregnancy?
Oh, well. Yeah, so you know, there's no good studies. We use calcineurin inhibitors in pregnancy. Right now, the voclosporin is formulated with ethanol in the pills. Now, this is a really tiny amount of ethanol, but because of that, people are suggesting it should not be used during pregnancy. I think that the company is diligently working on two things that I think are critical. One is they need a bigger size pill, because giving 6 additional pills a day is really hard for patients, like we discussed. And also they're working on a formulation that will not contain alcohol. And in that case, I think probably no problem with pregnancy. Belimumab, it's not approved for pregnant patients. However, I know patients on belimumab have gotten pregnant. They've done okay. That's not advocating to do that. I think what you're highlighting, however, is a critically important area, especially in this patient population, that we don't have a lot of answers, and we really do need to start looking at this. But yeah, so right now in my pregnant population, generally what I use, first of all, I do a lot of counseling about not to get pregnant during active lupus nephritis. That's usually not a good outcome for the fetus. But if that happens, azathioprine, I use azathioprine, I use steroid, and we use tacrolimus as needed. Mycophenolate has to come off, you know that. And ACE inhibitors come off once you know you're pregnant.
Okay, sounds good. Question about belimumab and the duration of using. So the first question, how long they use in general. The second question, talking about how long can you use it after achieving the clinical remission or response.
So, you know, having been involved in clinical trials for a few years now, this question is always sort of left. Trial goes X, then it stops, and then we're done, and you have to decide yourself. I actually, opinion-based, now this is my thinking. The way I've presented the data to you and my interpretation of the data, and I've presented all the data that are relevant, so I didn't skew the data one way or another. I believe belimumab finds its best use more in terms of a longer-term therapy. The trial went 2, and then we added 6 months on, 2.5 years. That's all the data we have from the trial to guide us. However, I will tell you that the additional 6 months, so 2.5 years of belimumab, there was no toxicity signal. Okay, so that's sort of slide 1. Slide 2 is, we know from our rheumatology experience that belimumab is given to patients with non-renal lupus for years without significant toxicity.
Right.
So let's think about this. If belimumab actually has some sort of effect on reducing flares and preserving GFR through whatever mechanism that may be B-cell dependent or may not be B-cell dependent, maybe long-term therapy maintenance, I hate the word maintenance, but longer-term therapy might be okay if the patient's doing well. Now, there's a two caveats. One piece of information for you and a caveat. Hermina Brunner, who's a pediatric rheumatologist, has published data using belimumab in kids with lupus nephritis. It tends to be pretty severe in kids. I'm sure you see that as well. And she showed in renal and non-renal lupus that belimumab also decreased the flare rate there. So that's an additional piece of information, I think, that helps support the idea that belimumab is doing something beneficial to preserve lupus patients over the long term. The other sort of thing that's interesting is there's been a handful of case reports now, and we're trying to put the data together of brand new lupus nephritis in non-renal patients on belimumab. So I don't know where that comes in. So to answer your question specifically, I think belimumab could be a long-term drug. It's probably safer to use over more than 2 years. Hasn't been studied. Nobody's going to say that and put it in the guideline yet. But I think experience would suggest that it could have actions that would benefit with long-term use.
Good, great. Another question, also you maybe already mentioned something about it, and the question about this drug still new to be used, can be used for induction from start, or only use as a backup and maintenance therapy, and you just maybe your ideas how to
exactly. So everyone, you are not alone. Everyone is struggling with this decision. Yes, you can use in the United States, where both are approved, you can use either drug for induction therapy. Because of all the reasons I listed at the beginning of the talk, you know, you're adding on, it's costly, you know, all of these things.
Right.
I wanted to sort of differentiate. Now, I'm the first one to admit, since a lot of what we do in the lab is biomarker research, if we can discover patients a priori at the beginning, biopsy, you're ready to go, patient X is going to do really well with mycophenolate alone, leave them alone.
Mm-hmm.
Patient X is not going to respond to mycophenolate alone. You need to add something. And then even better, do we have a biomarker of response for that would require belimumab or voclosporin? We don't, of course. That is sort of where many of us in the field really want the research to go. Now we're having new drugs. In whom do we use those new drugs right up front? And that is, it's a wonderful question. I don't have the answer, obviously, but what I presented to you was sort of how I justified. I do think we as nephrologists, and certainly in my country and probably in yours, you know, we do have to think about ourselves, not simply treating one patient in front of us, but for the global healthcare economy, we want things to be reasonable. So that is a driving force, and the new drugs are costly. You know, and so I think the algorithm I presented is not unreasonable, but if you said no, the trials were done up front, and I wanted to use the drug up front, I could not counter that argument. And I'm okay with that.
Okay. Another question talking about histological changes in voclosporin group long term.
This is a great question. I love that question. I had the same question, okay? When we talked about designing this trial, I told the folks that we were discussing with at Aurinia, we really need to have a rebiopsy component in this because everyone wants to know what does a kidney look like after a year on voclosporin. And the good news is they agreed. Okay, so we actually have repeat biopsies on, not everyone, of course, but on a decent number of patients. The biopsies are being analyzed. Actually, a lot of the analysis is done. our lab has done some transcriptomics on the biopsy. We have histology on the biopsy, and we're getting ready to put these data together and present them to the community. So stay tuned. That's a great question. Had the same question, and I think this will be very informative for us. And I'm not going to give anything away, okay?
Maybe this actually bring another talk in the future about.
Listen, I love to talk about histology because, as you know, we like to do repeat biopsies, and we have some very interesting data. So maybe when we start having in-person meetings, I can come and visit actually, and because I've never been.
I see. Another point, using dose medication, any limitation with GFR? I think you have an idea or you have an approach.
Yeah, there's no real limitation for the belimumab, the monoclonal antibody. You know, our FDA is put the label as greater than 45, greater than or equal to 45 EGFR. I use it when the EGFR is lower. You probably use tacrolimus and cyclosporin when EGFR is lower. I follow the patients very closely. I see what happens to their creatinine, but a lot of patients with native kidneys, 2 native kidneys that otherwise are pretty good kidneys do okay. I will tell you, though, that if you are a person who likes to follow levels, I don't use calcineurin levels for dosing per se. I use calcineurin levels for adherence. Are you taking the medication? I don't know what trough level is therapeutic in lupus, okay? Because we haven't done those studies, right? This is a big omission. You have all of these wonderful data of patients being treated with background medications, and they're all stored away, and blood is stored away somewhere, and nobody's asked, I mean, we've all asked the question, but nobody's actually done it where we've looked at levels and tried to correlate levels with response. You cannot get commercially levels of voclosporin, okay? Voclosporin has a very linear dose response curve as opposed to the other calcineurin inhibitors. And so there is no sort of kit to do the levels. Levels can be measured in a specialty lab, but that's for research purposes only. So just be aware of that. There's no way to get levels, at least right now, on voclosporin.
Great. Actually, there are a lot of questions. I was trying to answer most of them. I'm not sure.
I'm okay to stay if you guys are okay. I know it's late there, okay, but I'm fine.
Okay. So a question about a patient who developed end-stage renal disease due to lupus nephritis, had transplant, then later on developed recurrent of the disease. Is there going to be a rule for switching voclosporin instead of tacrolimus to achieve the remission?
Boy, that's an interesting question.
Is it?
I don't know. You know, it's really interesting that voclosporin was sort of had a very tiny surge into the transplant field many years ago, and it never caught on, right? It just, nobody ever used it. I'm not entirely sure why. So your question is, you know, first of all, I will tell you that the fact that your patient had recurrent lupus nephritis under a transplant regimen is pretty unusual, right? I mean, you know, right. I hope a lot of our patients don't get transplant, but we've certainly had some. They've done extraordinarily well. I very rarely see a recurrence of lupus nephritis or lupus. So the question is, if they had been maintained instead of, you know, on tacrolimus or cyclosporin, whatever your transplant center uses, would they have done better? No idea. You know, a head-to-head comparison of the 2 calcineurin inhibitors for lupus, I would guess is never going to be done. I don't think anyone's going to do it unless somebody did an investigator-initiated trial. I don't think any company's going to do that.
I see. So from cost effective, there's a question about difference the cost between two medication.
Yeah. So you know, what I showed you on the cost effectiveness, I put them side by side in the table. But if you read the article, and I suggest you take a look at it, I will tell you it's really hard to read in the sense of trying to understand how they did the modeling to get the numbers. It's really easy to read otherwise. It's just straightforward if you just, you know, read the results and everything. Anyway, they basically say up front, we are not comparing directly the cost of voclosporin to belimumab. We're comparing the cost of adding voclosporin to baseline therapy or adding belimumab to baseline therapy. Undoubtedly, our brains compare the two because that's what we do as people. We always do that. You know, so in my little model of the future, if you believe any of that, the use of voclosporin is certainly not going to be modeled at 3 years. In fact, it may be modeled at less than 1 year. And so those costs in which they made the assumption of using the drug for 3 years is probably, you know, not a good estimate. Similarly, for belimumab, I think more and more people, if we're starting to use it at home, right, and using the subcutaneous dosing for a longer term, that's going to be cheaper. So yeah, I think the drugs are costly, but I also think that if they're used correctly, the costs are going to be mitigated because we're not going to be using them as long as what was estimated in that particular trial. You know, but again, if you're a healthcare economist, you might interpret these data differently than I do, but it's really hard. And the other thing you have to think about is, to me, you know, we're nephrologists, so if we keep a patient off dialysis, then in my country, you save $80,000 a year for the medical system, right? I don't know how much it costs in Saudi Arabia, but I'm sure it's expensive. What insurance companies tend to do is think about sort of the medium term, like 3 years. Well, of course, you know, end-stage kidney disease comes way out here. And so it never gets modeled into this idea. And so when you look at maybe the whole picture, if you can prevent 1 year of dialysis and save $80,000, did that cost, that brings sort of the cost of $150,000 down a little bit. That's the way I think about it. And I don't know if that's the right way to think about it or not, but I try to take in the whole perspective because, again, most of our relationships with lupus patients are not short-term like AKI. This is a long-term endeavor. That's the best I can answer that. Otherwise, I don't know. It's expensive.
It is. It is. Okay. One question asking about any studies looked for the role for long-lived plasma cell after anti-CD20 treatment in restoration of autoimmune disease. And what do you think the sequential treatment with anti-CD20, then anti-CD38?
Yeah. So yeah, I think that's a great question. And yes, I love that idea. And I have thought about that quite a bit. There's not a lot of data, but we do have some data that looked at, actually, they did it the reverse of what you said. So they came in with an anti-CD38 or with bortezomib. Okay, so that's not a monoclonal, of course. And the idea was kill the plasma cells immediately. Okay, kill all the plasma cells immediately. And what you could see in some of those studies is a very sharp decline in anti-double-stranded DNA as an indicator of an autoreactive B cell or plasma cell or plasmablast. But what you also saw is that if you didn't continue, these antibody levels came back up quickly. If you added rituximab, and these are really tiny studies, you could actually keep the antibody levels down low. So now, again, I know that double-stranded DNA is not necessarily the best or most faithful marker of disease activity in lupus nephritis, but just using that as an example of an autoreactive B cell, the idea of sequentially targeting plasma cells and then the B cells that will make them is highly appealing, okay? And so I think people are really wanting to start to study anti-CD38 in lupus, but I don't think that's going to be sufficient. As you said, you're going to have to add something else on board, and that could be, you know, a Rituximab or an Obanituzumab. And there was an article in the New England Journal of Medicine. It was like a single case report, or two cases. One was refractory lupus nephritis, and one was refractory non-renal lupus, where they used anti-CD38 followed up by, I think Rituximab, but I can't remember, but followed up by more immunosuppression, and they actually got the patients under control. So yes, I think that is a viable idea, and I think it's very worth being explored.
Okay. Maybe this is the last question. We close with it. Any use of folgosporin in children?
Oh, so there must be pediatric nephrologists in the audience, and you always feel left out because we never do these studies in kids. Although Belimumab is being tested in kids. You know, obviously I don't have data on that. We use calcineurin inhibitors in children with kidney transplants. Is there a reason to think a calcineurin inhibitor would be bad or harmful in a growing child? I can't think of one off the top of my head. You know, other than that, it's a fairly well-tolerated medication, at least so far when I've been using it. So I think it's a great point. I think that we need to get the pediatric nephrology community sort of to get kids into some of these trials to really answer the question. But I think that's an open question right now.
Okay, 1 second.
So I kept everybody up late.
Yeah. No. Actually, it's interesting. If you see the audience, most of the audience is still there. Oh. And just to make sure, highlight all the points. So one of the question was, maybe I didn't mention that, about availability of Belimumab in Saudi Arabia. And the answer is approved in KSA. So that's good news. And maybe we'll see a lot of nephrologists gonna use it in the future. Maybe we covered most of the question, and I apologize for any question we didn't mention. Maybe some already we talked about during the presentation, or do you want to take the time to repeat it again? Again, it was my pleasure to be with you guys here. Thank you, Prof. Rovin, for all your time you spend with us answering questions. And now I'll return the microphone to Dr. Mohammed to conclude this meeting.
Okay, thank you very much, guys. I think really it was very interesting discussion we have this evening, and really I'm sure everybody enjoying this. I'm glad to share with you that really there is more than 800 participants attending this discussion, and they enjoy the discussion, and until the end now, we are seeing more than 50 participants still in the room. They're listening to this discussion. So really, this is very something good that we see it. A very interesting discussion. And on behalf of the society, really, I'd like to thank the Prof. Brad Rovin for his talk and for accepting the invitation from the society. Also, I would like to thank also Dr. Samir Al-Qasimi, really, for moderating this session, and there were really excellent moderation. And again, I'd like to thank our colleague from GSK company for really sponsoring this event. I will not forget to thank our really participant who really have a really good and active participation with this kind of an excellent activity tonight. And also will not forget to thank our colleague from the Event Troop company for really for their technical support and make this really possible event tonight. And just before we conclude, really, I just have an announcement that really the next webinar that Society going to arrange, it will be on 22nd of June. So please mark your calendar, 22nd of June. Next month, we'll have another webinar, and you can visit the Society website to see the detail of this webinar, and you can start to register in this webinar soon. So again, thank you very much for everybody, and I hope to see you soon, and goodbye and good night, and see you hopefully in Riyadh and physically, Prof. Brad Rovin.
Great. Thank you all
Bye-bye.
for inviting me. Appreciate it.
Thank you.
Bye.
Bye-bye.
Thank you very much, Shura.
Thank you.